minutes from our July 8th meeting. We will take a motion on those in just a moment, so you can pull those up and look through those if you'd like. Okay, it is 1:33, so we will go ahead and kick off our meeting today. Welcome, everyone. I am Jennifer Strohecker, Medicaid Director, the Director of the Division of Integrated Healthcare. Wanted to just thank you for joining our call today and rejoin our efforts to have our complete working group together again. We haven't met in a month, so we've taken some time to meet as subgroups and really delve deeper into our proposed options for an integrated benefit for our TAM population. And today we are back together to look at that. So if you could, as still others are logging in and joining, as a reminder, if you are a designated member of the working group, would you please put your name and affiliation into the chat so we can capture your attendance at this meeting? Thank you for doing that. We're going to first start today by doing the approval of the July 8th meeting minutes. So if you would take a look at those. Those should have been emailed out to with our agenda today. If you could take a look at those minutes and review them if you haven't had a chance. And when you are ready, I'm happy to take a motion on approval of those minutes unless we have any additions or changes to the minutes.
Jen, this is Pat Fleming. I read over the minutes and they look pretty good to me, so I'd make a motion to approve the minutes as presented.
Thanks so much, Pat. Do we have a second?
I'll second it.
Okay, thanks so much, Nina. Any opposition to that? Okay, all in favor of approving the minutes as written?
Aye.
Okay, thank you. Motion passes for these. I'm kind of asking, maybe you can raise your virtual hand to indicate that you are on board with that. If there's no changes, thank you so much, everyone. Okay, thanks so much. Great, so the minutes have been approved. Thank you. Let's move on to our second agenda item. We've committed with each of our meetings here to really bring forth any issues that have been identified as operational issues and to share those with the group and talk through where we're at. So there have been no new operational issues identified and brought to our Medicaid team for any discussion. So at this point, we don't have any updates today. So if you do have an operational issue, this is, maybe a challenge with claims reimbursement or a payment of some sort, we'd love to hear about that. Please let us know. And we had committed to bringing those issues to this forum for discussion. But please contact us. Dave Wild will put his contact information into the chat as a point person for working with you through some really claim level issues you may be experiencing around payment or any other challenges you may have. So please send those in to us. We'd be happy to work with you to address any concerns or problems you are having. Okay, with that, we can move to item number 3. And I saw Laura join our meeting. So Laura, thank you so much for joining today. Laura's going to give an overview to this group, has been asked to present an overview of our Utah Behavioral Health Assessment and Master Plan project. So we're really honored to have Laura here with us. And Laura, I'm just going to hand it over to you if you would, please.
Great. Thank you so much. And am I able to share my screen?
Laura, if you do the up arrow, it would be present now in the lower bar of the meeting. Push the up arrow, and there you go.
Perfect.
Thanks, Laura.
All right. Well, thank you all so much for letting me join the meeting today. I'll just give a quick overview of where what the project is and kind of where we are in the process. And then happy to take any questions or ideas or thoughts people may want to share at this time. But my name is Lara Summers. I probably know most of the people on this call, or at least you may have received an email from me at some point. But I'm the Senior Healthcare Analyst of the Kempsey Gardner Policy Institute, which is associated with the University of Utah, actually the David Eccles School of Business. And we focus on economic, public policy, and demographic issues. And we are currently working with the Utah Hospital Association and USAVE Plus and the Department of Health and Human Services on a behavioral health assessment and master plan. And I know some of you were involved in our work that we did back in 2019. We did a review of Utah's mental health assessment. At that time, just due to scoping issues and timing issues, we really just had to focus on the mental health side of the system, and it was primarily focused on adults as well. We provide a little bit of information and data on youth, but a lot of the recommendations that came out of that report really focused on adults. So we knew coming out of that process and that project that we always wanted to have sort of a second chance at it and to broaden the view to focus on the substance use disorder side, as well as a broader view of the behavioral health system in general. So this time we are trying to gather that comprehensive view of the entire behavioral health system. So we're looking at both mental health and substance use disorder. Certainly those two go hand in hand. We are looking at entities that kind of connect into the behavioral health system as well. So the court system, law enforcement, housing has been a big issue that's come up in a lot of the discussion groups that we've run so far. So again, we're starting to look at housing and how that plays into the system as well. We're trying to take the spectrum from children to adults to the geriatric or senior population. Again, trying to get as comprehensive view as possible so that as we move forward into the next phase, we can really bring in that entire perspective. I would just note that we are also working with Health Management Associates and Levitt Partners. So for those of you who are maybe not familiar, Levitt Partners was recently acquired by Health Management Associates, but they bring a great sort of national perspective. They do a lot of work nationally and in other states. So we are partnering with them on this project and really going to be leveraging them as we move into the second phase of this work, which is developing a roadmap or a set of recommendations for the state moving forward. So just in terms of our process, it's kind of divided into three key areas. So the first one, which we are engaged in now, is the environmental scan, where we're really working to assess all of the different sectors that are both within and connected to the behavioral health system. We are working to understand all of the current initiatives that are taking place, like this group, as well as barriers that exist to providing services and accessing care. We're also conducting some additional research and analysis. As part of this process, and some of you may have participated in these groups, so if you have, thank you so much. We're actually conducting 27 discussion groups and in-depth interviews with individuals. We've conducted 19 of those groups to date. We've got 2 scheduled for September, 2 scheduled for October, and 4 that are in the process of being scheduled. And then we've got sort of a list that we're keeping of groups that we plan to round back with or may plan to round back with at a certain time as well. So again, hopefully you all have had an opportunity to participate in some of those groups. If you haven't and would be interested in sharing your perspective, please feel free to reach out to myself. I'll make sure I put my email in the chat before I hop off so that people will have that. We'd be happy to make sure that you get integrated into a group, or would just be happy to have a conversation with you as well to get your thoughts on the system. But we're, again, conducting these groups to better understand where some of those gaps and challenges are, some of those ideas for improving the system, and some of the success stories as well, because we also want to make sure during this process that we're understanding what is working well so that we don't have any of those unintended consequences of taking away or replacing something that is actually serving the state of Utah really well. Our second phase is we will be conducting an assessment. So we're kind of starting to move into that now, but we'll be doing that more this fall, early winter, where we sort of take all of our findings from the environmental scan, assess where we want to, with our executive committee that we're working with, which like Pat sits on, Greg Flicks on, Greg Bell sits on, and I know many of you others are part of that as well. But understand kind of where those gaps and challenges are that we want to prioritize, where we can focus change on, what are some of those priority areas that need to be addressed. And then that will ultimately move into the master plan generation, which will be developing those set of recommendations, looking both at what would work well in the state of Utah, but has worked well in other states and nationally as well. So just as a reminder, I think I ran through this information already, but we're currently in the process of discussing these discussion groups and interviews. So conducting 19 groups have been conducted. Again, we've got 2 scheduled for September, 2 for October, and 4 are in the process of being scheduled. I think we've talked, I haven't done the official tally, but I think we've talked to over 100 people so far, probably closer to 200 if I was actually to do the count, but we want to make sure we haven't missed anyone. So again, I'll just reiterate my previous comment that if you haven't had a chance to be part of these groups, would like to be, or would just like to have a conversation with us, please feel free to reach out to myself and we can make sure that that happens, because we know that it's important to make sure every voice is heard. So this is, again, sort of the continuum that we used in the 2019 report and kind of is our rough frame. But again, we're trying to look across the continuum of care all the way from community and education services to acute inpatient care, considering both promotion and prevention, as well as stabilization supports and wraparound services. Again, I think I mentioned that one of the issues that's really rising to the top that's kind of outside the behavioral health system, but it's a big reflection of our current state's issues right now is housing. Everybody is struggling with housing right now, but that certainly has a rippling effect on the behavioral health system. Whereas if people don't have appropriate housing, it can impact their ability to get treatment through the courts. It can impact their ability to get discharged from an inpatient facility. It can impact their ability to get into community services. So again, thinking really broadly about what we can do within the system. So, and then just in terms of our timeline, again, we're trying to wrap up the environmental scan by end of September. The assessment phase kind of by end of November-ish, and then working on that master plan generation through spring, early summer of next year. So, but I will pause there and happy to answer any questions or address any concerns anyone may have. And Pat, I don't know if there's anything you want to add. Pat is, obviously serving as the USAVE representative and lead and as part of this initiative, and has been great in terms of making sure that we're connected into all of USAVE's working groups, as well as a lot of the other initiatives that are going on throughout the state.
No, I think Laura's just done, and her team and HMA and everybody has done such a great job on this so far, and we've got really good buy-in. But I think this does, in the department has been supportive of this also. I want to emphasize that. And the key thing we're looking at is we're not just looking at the publicly funded behavioral health system. We're also looking at the commercial insurance side, paid side. So, because Laura had I don't know if you're going to show that graphic on this, Laura. You're probably not going to go into that. Are you going to go into that level of detail?
I'm not, but I can pull it up while you're talking.
Yeah, that was really interesting. Is Laura has a graphic that shows the different sectors in behavioral health in Utah and who's paying for what, and it's very interesting. And we know that our commercial insurance partners are very, very important. Our large employers, and so we're trying to reach out to them also. And so because the key thing is this, is making sure that people that have the first access to any behavioral health, whether it's through publicly funded or commercial insurance, whatever it may be, they get good care and good services. There it is right there. It can be very frustrating if any of you have ever had family members that have had to access care. There's so many different doors to go in, and a lot of times the burden of finding out where you should go is left up to the consumer. And although we think the consumer should be in the middle of all these decisions, a lot of consumers are not prepared to do this. So this was really interesting. We saw this today. We had our meeting just before this one. And so we like you all to think about this a little bit and to help us access some of these different, especially on self-funded and commercial insurance. We really would like some help on that. Our next meeting, we're gonna really do a deep dive into more of this. But anybody on this call that's got ideas on different groups we should be talking to, we sure would love to hear it. And you can just let me know, Laura know, put it in the chat somehow, and we can round out on that. But again, this is really important, and we really are looking at the Department of Health and Human Services as a major partner in this. So that's all I have to say, Laura. Thanks.
Patrick, thank you. And Laura, thank you for putting this slide up. This is Eliana at Select Health. So we just had our UHIA meeting this morning, and only a couple of our members were aware of this work going on. So I would love to have you, Laura, and whoever you'd like to join you, come to our UHIA meeting and educate our commercial payers on what's going on with this work.
Perfect.
That would be great. The other question I have is, how is this going to work with the One Utah Collaborative? And then the other project that's going on is our statewide telehealth network in all of our public schools. And a piece of that work was intended to be focusing on behavioral health, telehealth. So is there some work happening around that project as well?
Yes, great suggestion. Then first, we would love to come to your meeting. I think we're in the process of scheduling a discussion group with some representatives from that association, but we'd also love to come and speak to the broader group as well, just knowing how, making sure that everybody's voice is represented. So I'm happy to follow up with you on that, Eliana. One Utah Collaborative, we are definitely staying apprised of that work and want to make sure that ultimately our whatever master plan or roadmap is developed from this work aligns with what's coming out of the One Utah Collaborative as well. So I know a lot of the folks that are on our executive committee are involved in the One Utah Collaborative. I've been involved in different subgroups as well. So we're not directly involved with the One Utah Collaborative, but really trying to make sure that we are aligned with what they're doing and certainly not duplicating or, hopefully not like moving away from anything that they're doing as well. So that's what we're trying to do with all of these different initiatives in terms of both the environmental scan as then when we start the master plan generation is that is part of our scope of work, is making sure that we're as aware of as much as possible of some of these key initiatives so that we can make sure that our recommendations align with and support rather than detract. So and then the statewide telehealth network, that's great to know about as well. That's actually one that I probably have heard of, but wasn't aware of. So I'd love to follow up and get some additional information from you as well, because I know telehealth, particularly in our rural areas, is going to be one of the key issues in terms of improving access. So
yeah, so there was funding passed to support that project, both for procurement of devices as well as broadband build out. And that passed through executive appropriations in this past legislative session. So as far as I know right now, it's sitting in procurement.
and I thought I saw somebody raise their hand, but maybe not.
Yeah, Laura, it was me, Jake
Great.
Schoaf, with the Phoenix Recovery Center and UBO. We have you scheduled to come to our next board meeting on the 13th of September. Are you still planning on coming to attend that?
Yes, we are.
Wonderful.
So as long as you're still planning on having us, we will be there.
Yeah, we had to cancel our last meeting due to conflict with our work group, actually. So we had a lot of members that there was a conflict. So hopefully the 13th we don't have a work group. So, but we're eagerly awaiting your presentation. I know a lot of members are excited about that. So we'll plan on it.
Sounds great. Thank you. And I would just note, I did drop my email into the chat. It's just laura.summers@utah.edu. So if there are any, if anybody has any questions, concerns, or just would like to chat or get more information, please absolutely feel free to reach out. So.
Thank you, Laura. Okay, moving on to our next topic, our sub working group updates. Thank you, and also thank you for everyone's participation there. As we move into our sub working group updates, we're going to start first with our ACO managed care model. So first, I want to start by thanking everyone for your engagement in this process. In the last month, we have had, I believe, one ACO managed care model meeting, one fee-for-service case management meeting, and one RFI integrated plan meeting. From that, we have followed a framework of really working through the questions that were defined as talking points and areas for conversation. If we were to propose one of these models, we walked through these areas. You're going to see today that this information was collected during the meeting, and that this is going to be reviewed from you with you. We'd actually encourage open dialogue around each of these areas to make sure we're capturing all the thoughts and views from each of these areas as we look through these proposals. Another piece today that we also want to recognize is that we may need to re-meet as subgroups again. So while we've met once, we've had a good starting discussion, we recognize there is more material and more evaluation that we can do in our sub-working groups. So wanted to state that from the start, that this is not the end. We are bringing this back for discussion with the whole group, and we intend, if needed, to take this back into the sub-working groups to be able to have another discussion and more work done on this after our meeting today. So with that, I'm going to transition over to Eric Grant, who ran the ACO Managed Care Model Working Group.
Okay, Jen, I'm going to go ahead and share my screen to share those notes that we took during that meeting. So anybody who was present for that meeting, if I get something wrong or it wasn't captured in the notes adequately, please feel free to speak up. So as you can see, as Jen mentioned, we went through a specific framework and tried to align it around specific questions that we asked the group to work on to try to answer. So the first one was about the geographic assessment of where this type of model would be applicable. And, so the notes we took, we talked specifically about, should it be focused on just Salt Lake County, or do we want to consider the Wasatch Front counties? In the discussion, the group kind of gravitated towards, we would consider this for all the counties that are currently engaged in the UMIC programs. So where we would basically start with those counties and then potentially consider some other options for the other counties outside of that area, or outside of that contracting model. We then talked about the population, specifically the subgroups within the TAM population. Did we want to divide them up and do something different from one group or another? And as the group discussed, we felt that it was probably best to leave the TAM population as a whole together with this solution and have them all participate in the same model rather than subdividing it. So then we moved on to talk about what some of the pros of the model were, and then we'll get to the cons obviously next. The pros we identified were that the ACOs had a very robust management staff and flexibility for growth, so it's scalable. And also that they currently perform case management within their model. And so that's kind of a nice segue into bringing this population in. There's true integration at the provider level, not just at the payer level. They have a line of sight into the cost drivers from multiple agencies. B3 services were a big topic point as well, that this is a great way to get B3 services for this population that they may not be getting right now under the fee-for-service model. It also supports the continuity of care as members move between plans. So for example, if somebody were in an ACO, or sorry, started out as a TAM member and then eventually moves into a non-TAM category of aid, if they were already in the UMIC plans as a TAM member, as they move into that non-TAM category of aid, they could stay with the same health plan essentially. So it kind of provides for some continuity of care around that. ACOs are known entities. They have established systems within the state. They can address geographic limitations. They also have the flexibility to be a little more creative around how delivering care, whereas in fee-for-service, we're a lot more rigid in what we can do there. Also, just the management of the behavioral health and physical health issues that they're already doing within the UMIC programs. So then we moved on to what are some of the cons of it. There's a difference in how the ACOs are structured. Some are vertically integrated and some are not, and there might be some contracting challenges that come as a result of that. There have been some challenges on the payer side with the UMIC plans versus the fee-for-service model. Also in reimbursement, there's potentially lower reimbursement with a greater administrative burden. The financial structure of reimbursement, the ACOs, doesn't necessarily capture additional services delivered that are essential but have no lower or no reimbursement presently. Providers, this is kind of a con in that providers have to bill multiple entities instead of one. Right now with fee-for-service, the providers bill Medicaid for the TAM population. They bill the state agency. With this, they would have to bill one of 4 UMIC plans. There was talk about that this may shift some of the burden of care to the local health departments. There's limitations on the current ACO benefit design. It doesn't support a lot of creative strategic expansion of service delivery to meet needs. And some of these cons can be addressed with more engagement into this model. We could work on the structure to align the incentives for the providers and payers to kind of overcome some of these cons. Now, the proposed timeline we talked about, we proposed that it be a slow, methodical process rather than just kind of an all at once. And so that's the discussion about, yes, we should just focus on those UMIC counties first and then potentially consider other options for the counties that are outside of that area. There were some questions about who would conduct the case management. Would it need to be at the point of service level or at the ACO level? And collaboration between case managers in both of these settings. We need to still work out some of the reimbursement for case management services that are not billable. And then also we would want to add some contractual language that would create greater provider engagement in the model and try to align the incentives for the contracts to better fit the desires of the group as a whole. So those are what I have down in the notes and the discussion points. If anybody else was present in the group, if I missed anything, please feel free to speak up and add to these in any way. Nina, I think you were first. You're still on mute, or at least I can't hear you.
Okay, is that better?
That's much better. Thank you.
Perfect. I think a significant part of our conversation last time too was looking at something maybe completely different than kind of analyzing the pros and strengths of the ACO model that we already have and what we're fairly familiar with. I think Dr. Whittle brought to the table some unique concepts. And I think that's something that bears looking at, because I think that was maybe one of our tasks was to look at models in general, different types of ACO models. And I'm not so sure I saw that in the notes.
Okay. So looking at different types of models. So I will make sure to add that. I'm just going to add it down below at the bottom here.
So Eric, we're capturing note. I can capture notes if you want to go to that section, because I'd like us to kind of maybe go back. I know that was a pretty quick presentation to kind of run through these areas. And for some of you who hadn't seen that, maybe we just want to give you a chance to look at this. So Eric, I can go ahead and grab those notes if that would be helpful to make sure they're included.
Sure, you bet. Now, where do you think that would belong, that specific item? Would that be under the geographic or population? I'm trying to think of where would be the most appropriate place to capture that. Or does it not fit within the structure we have? Okay, I'll just trust that you're capturing that, Jen. Thanks. Patrick.
Yeah, Eric, can you go to the cons section?
Certainly.
I just want to make sure I got this right. Number 6 on the cons. May shift some of the burden of care to local health departments?
Yep.
Or is that local behavioral health authorities?
See, and I'm trying to recall the conversation around that.
Yeah, I don't remember either.
I'm just looking at in the perspective right now. I don't know how much care the local public health departments provide on the physical health care side, but on the behavioral health care side, the local mental health and substance use authorities provide a lot of services. And I'm just wondering if that's a distinction there, or maybe I'm just not reading that correctly.
Yeah, we can definitely capture your concern there and add to that. Yeah, it's probably more of the local health authorities than the LHDs.
Local mental health authorities?
Yeah, so
No.
I think we'll just capture that in the notes.
Okay. Thanks.
Nina.
I'm sorry, did you say you were going to send this out to us? This summary?
Certainly. Yeah, we can
That
share
would
it.
be very helpful. Thank
We'll
you.
send it out at the end of this meeting, Nina. I think right now we'll try to capture some of the dialogue. And I want to make sure too that in the area that you were mentioning around the typical model, could you, one of the items we talked about is what version of managed care is considered, right? UMIC plans, ACOs, PMHPs. I think that may be along the vein of what you were referring to with your comment. Would you sort of articulate again, like where you'd like us to add your note and what you were thinking?
I will do my best. I think that that's almost a separate category because it's almost as if we're looking at different complete styles of ACOs. Is kind of my understanding of it, and maybe Dr. Whittle can address this better. But I think part of it was looking at, this is, to me, I read this almost as if it's an analysis of the ACO models we have currently. And I think one of our things we were tasked with is looking at all kinds of models that might even be slightly different from the ones that we have right now. And so that's almost like a different section. This is an analysis of what we have now. This is another proposed model.
Yeah, I think
That's how I
Nina,
read it.
I was gonna say, Nina, I think that was captured in another subgroup that was led by Brent Kelsey. So this one was specifically to look at incorporating it into the ACO/UMIC model right now. And I think they were exploring some other ideas outside of that model. Or maybe I'm misunderstanding.
Yeah, no, exactly. And is it okay if I jump in real quick?
Sure.
So yeah, it's probably way premature to throw something a detailed discussion of that onto the table here. The idea really is how to support the ACO system we have and what it goes back to that earlier discussion of what solutions have been found to support the ACOs, especially in this discussion, to support the existing ACO structure to make it achieve the goals that we all know we want to achieve in providing the best care possible. So, and there is efforts to kind of look at strategies like that. So really it's a look at how to support the system the way it's been established and support the ACO model to accomplish what it's supposed to accomplish.
Got it. Okay. Thank you.
Okay. Any other discussion to what the subgroup talked about, or any questions or concerns that folks would like to take back to the subgroup? Dave.
Will you scroll up? I had a question, but I lost it. But I think it was based on one of your
Cons or pros?
I'll go down. I think it was number 4 on the cons. What can you tell me what some of those services are that are essential but have lower or no reimbursements?
Yeah, would it be helpful if I touched on that?
Absolutely.
Yeah. So we've been, you know, putting on my historical hat and my current hat. We've been asking forever. There's all those services that don't get captured in the fees, you know, the fee system of Medicaid. You know, there's lots of ways to try and get to where we flesh that system out. The current system is incredibly complicated and depends upon braided financing with lots of, you know, individual solutions that are incredibly complicated, and I think all of us recognize would not be duplicatable in a clean managed care system. So, you know, the idea there is, how do we use the existing ACO structure to enter in, you know, and I'm going to use those buzzwords we all love. How do we risk share? How do we create value-based contracting to take the dollars and share them in such a way that we can fill all those gaps without having to duplicate the incredibly complicated system that's been necessary to fill in all the gaps in that Medicaid benefit design. And that, you know, that's kind of at the core of, I think, what we're all talking about is, how do we avoid the absolute disaster of not having a strategy to support those services between what we're doing today and what we want to be doing into the future. And so I know that's saying a lot, and that's not getting into any detail, but I think the recommendation ultimately would be, let's find a way to make sure that in the transition, all those services don't get lost in the wash.
Thank you. Eliana, I think you've got your hand up next.
Yeah, thank you. I just think I need a level set understanding. Maybe Jennifer, you can help with this. My understanding from doing political work federally as well as stateside is CMS is not supportive of filling in costs for states. So for example, these wraparound services, housing, transportation, things where the federal government's not comfortable doing a cost share with the state, but the state's 100% responsible. I don't think that scenario changes regardless of the way we deliver the care, but whoever delivers the care for those wraparound services that the state provides, we need to have a smooth transition so those services continue regardless of which way we go. So I guess what I'm just not clear about is, in this ACO work group, was there some issues that were highlighted where there's more of a struggle through the ACOs versus fee for service? Is that something that was talked about?
Yeah, I actually think it is on the cons list. Let me see.
I think that was item number 6, Eric. That is where some of the existing services today that you're talking about, Eliana, we want to make sure, like, that was sort of the exercise we went through, right? Of making sure we were able to identify all the necessary services that this population is currently receiving and that is necessary for their success, right? And making sure that as we look at, Dr. Whittle, to your point, how do we, if we're going to propose the ACO model that we have today, how do we actually build these pieces in so they don't fall through the cracks, right? So Eric, I'll pass it back to you. But I think that was a little bit of what item number 6 was meant to address.
Right. And I think a lot of that, I suppose, is with the state or with the counties, not sure, but that's not 100% on the ACOs. We need to have very close working relationships so we don't lose that benefit for our patients.
And that truly is the goal of this discussion here, right?
Okay,
like, if this is the model, as we carefully evaluate each of these proposals, how do we ensure in this model, if it's through careful contract language that details each of these elements, and we'll use something that we've talked about a lot, is ratio of caregiver or a case manager to patient, right? Like, is there a high touch? How do we achieve high touch that this population needs? What does that ratio look like, right? And maybe some of these contracting elements to ensure that these pieces are identified and met in the contract language. I'll let others speak too. But what are those solutions? What are the thoughts? I mean, this honestly was a 1-hour meeting. There is much more. I think we need to go dive deeper into to think about how we would actually implement this. And so one idea was very detailed contract language that would identify and make sure that each of these responsibilities was carefully detailed with the proper assignments, right?
Yeah. And more to that point, by the time we got to the con list, we only had about 15 minutes left. And so the discussion on all the stuff above it had occupied most of the meeting. So that was the part we were kind of rushing through just to meet the end time of the meeting. And so that's why when we started this today, Jen mentioned that we might want to go back and have these groups re-meet to kind of get some more detail in some of these areas that we just seemed rushed for time on.
I appreciate that because, you know, we're open to some constructive criticism and improvement. And I think we just need to level set that the benefits are what they are. You're not going to get more in a fee for service than you are with an ACO. It's just how we integrate them.
Sure. Emma.
Yeah, so I think one of the things that we talked about very early on in the ACO model that has not, I mean, it's come to fruition in some ways, but not as much as it probably could, is the fact that the theory is that if you pay the per member per month, and if everything was right in the world, there would be enough funding available in the administrative portion of the rates that the ACOs could do some of these creative things, like what some providers are doing now and what some of our prepaid mental health plans or the local authorities are doing. I think Adam brought up the as an example the other day, where he said, you know, sometimes the providers literally taking someone down to the DMV or to get their driver's license. You know, that's not something that an ACO typically does, or a care manager for an ACO. But I think we have to think creatively, because we do have a process where the ACOs can provide those non-Medicaid covered services. It is intended to be part of the administrative portion of their rate, but do we need to examine that and say, you know, maybe for this population, that needs to be somewhat different, that rate, that portion of their rate, because this is a more intensive population with more intensive needs. Or, you know, I've seen Scott's raised his hand again, maybe it's, you know, talking about in the contract, as Jen has mentioned, giving very specific direction to the ACOs about what kind of relationships they need to have with service providers and with the local authorities, and how to reimburse for those types of services with those other entities. So again, just keeping our minds open in terms of there are some flexibilities that we could pursue within the managed care structure.
Yeah, and I think that's what we were trying to capture in that note of the bottle note at the bottom. Sorry, I can't even talk today. Of trying to restructure the contract to align the incentives properly. I think that's, and again, we were pressed for time at that point. Scott.
Yeah, thank you. And Emma, I really appreciate you bringing it to that practical level, because I think the idea of having we have 4 ACOs, 4 payer-based ACOs. So the idea of having 4 different strategies to try and get to what we potentially could lose if this transition isn't as smooth as it could be, I think kind of scares all of us. So some strategy so that there is a kind of well, you know, I'm just going to say it, put an overarching organizational perspective that takes the collective wisdom of the system to guide that process. So it's not, you know, ACO by ACO by ACO trying to find unique solutions in this space. I think that, you know, I've been saying it for years. I think we all agree there really is one network in this space. There really is one group of providers trying to solve these problems. There's not 4 networks. There's one network. And so if we collectively, the payer-led ACOs and the providers, work in this kind of a structure to figure out the way to propose how to do that, I think we're way out ahead. The idea, and Emma, to your point, when we handed that creativity to the ACOs, we really handed it to a group that is cautious about making dramatic changes. ACOs, payer-led ACOs, are generally very nervous about managing risk. And so when the idea came up that somebody could change the rate or add a service, you're going to run into natural caution there, natural worry. But if the system says, yeah, but we need this, and this to be successful, I think then we have obvious collaborative good partners in the ACOs to collectively say, yeah, thank you for providing that guidance. Thank you for providing that support. Yes, thumbs up, we can move forward. So as long as we get to that place where collectively we identify those things that we need, we agree that we need those strategies to help us avoid the kind of pain our members could experience, then I think we'll be exactly in line.
Great, thanks. So I just want to quickly ask right there, the comments we've added on that item, does that seem to capture it, or are we missing anything with that comment?
Scroll down just a little bit more there, Eric. I threw several things in as people were, and if these need to be modified, certainly these can go out as well for modification, but.
Okay, it sounds like we're done with questions on that. Probably can move on to the next subgroup.
Yeah, just to make sure. Were there any other topics or ideas for conversation around the ACO working group? The one piece that I feel like we didn't really discuss is geographic assessment. And Eric, could we just visit that? I'm sorry.
No problem.
I want to make sure we kind of weigh in. Was that covered, that we addressed?
Yeah, we talked about it really quickly at the first, how we'd considered carving it up different ways. But ultimately, the group landed on that keeping it within the UMIC counties was the best approach, and that's what the group would recommend.
Is everyone on board with that? There was discussion that I think some of our early conversations were focused on Salt Lake County, but as we talked about it as a working group, sub-working group, it was thought, well, why limit it to Salt Lake County? We should expand it to all UMIC counties. And this, of course, then would address the large chunk of the population that is within sort of these 5 counties. There are rural areas then that would look at maybe a different model. So just want to get your eyes on that and your thoughts if there's any feedback.
Jen, Pat Fleming, I think the Wasatch Front, Morgan County, Summit County, Tooele County, all those counties together really is one market now. I know that a lot of the providers that traditionally have served Salt Lake County are now branching out into other areas. And I think if the right incentives are being provided, payment incentives, market incentives, I think they would expand even into southern Utah County, provide services up in Weber, any place else. So I do think that maybe we should be thinking about the big urban core corridor, but include Tooele, Summit, and Morgan County in that also. So I think then we probably get about 85% of the state then if we do that.
Great. We'll add that to the notes.
Hey, Eric, one other comment. One of the things that I think has come up in the past, and we've had some discussions about it, is the fact that it would be, I think, best for the individuals to align their service delivery systems. I mean, this is what some of the discussion that we've heard, and I think, Healthy, you brought this up quite a bit, but I think it's a valid point because people go somewhat back and forth. They haven't obviously during the public health emergency, but they may be TAM and then they get a job and their annual review comes up and all of a sudden they're no longer eligible for targeted adult Medicaid, but they are still an adult Medicaid expansion member. And so just by virtue of the change in their eligibility category, they end up in a different service delivery system. One of the things we talked about is one goal should be to keep the service delivery system somewhat consistent for this population, especially since they may go back and forth somewhat between categories of eligibility. So, Pat, I think that would be the only concern, would just be to make sure that we're aligning that as well, so that, you know, right now UMIC is really only in the 5 major counties, you know, basically Weber, Davis, Salt Lake, Utah, and then we've got Washington County. And so the thought was, at least initially, to start there. Even if we expanded, I would say if we were going to expand to other counties, we'd want to expand all of UMIC to include for the adult Medicaid population as well. Again, just so they can have consistency of service delivery system.
Yeah, that's well said, Emma. And it gets to that continuity of care discussion we had about, yeah, because people do tend to switch between the different aid categories, and it's better to keep them in the same kind of delivery system over that time. So yeah, thanks for that comment, Emma. All right, any other comments or concerns before we move to the next subgroup? Okay, sounds like there are none. So Brian, I'm going to turn it over to you.
Yeah, Jen, did you want to make any note before I began?
No, that's great, Brian. I will say that Brent will not actually be joining us today. So we will just go through this one other subgroup, and then we will pick up the next time. So we can give this one 30 minutes or so if that's what it needs, just for discussion. I don't want the working group to feel rushed on this, just simply because we had another item on the agenda. So
Great.
Thanks,
Great.
Brian.
Yeah. Yeah, thank you. And thank you to all the participants that took part in my subgroup. You'll notice a little bit of deja vu because we ended up discussing a lot of the same topics that were discussed in the ACO group, just with the different lens. And the overall topics are the same. I've just reordered it a little bit to reflect how the discussion took place. So one of the first foundational questions was kind of what we were just talking about 15 minutes ago, about what does case management look like and what is actually being done by providers. So one of the first questions is, what does the department suggest, envision in this model, in the fee-for-service plus extensive case management structure? And to be clear, that this is kind of the purpose of these delivery work groups, that we're looking for your input in that. So it was emphasized by some of our good providers that were part of my subgroup, in particular Adam, Sean McMillan, talked about how much they do as providers, more than just connecting individuals with medical care, but actually addressing life activities. So getting individuals to get a driver's license, addressing education needs, legal concerns. Obviously, housing is huge, but not all of those, I think Dr. Whittle, you made this point, not all of those correspond to a procedure code on a fee schedule and is reimbursable under today's model. So that was a point of discussion for sure. One of the potential options is to use the same kind of structure that community health workers do, which do focus on more than just medical care and some of those social determinants. In any case management structure, it was certainly emphasized that we need to make sure that rapport and trust is developed, and that coordination between case managers and the providers is a key element. Jen just mentioned a moment ago about the ratio of members to case managers, and I did capture this, that Molina, this is among their restricted population, but they do have a ratio of 1 to 35. Moving on, So those were kind of the foundational elements. And if anyone wants to jump in, just raise your virtual hand. I can turn to you if there's comments along the way. So discussion about what the pros of the models are. So to be clear, some case management activities are already undertaken by the department. With our home and community-based service populations, like our aging waiver, new choices waiver, to name a couple, we already undertake that. So case management is not foreign to us, but that is something, if it were undertaken by the department, it is something we are familiar with. We did note this. We ended up noting it in both the pros and the cons because there is at least a potential of a payment model where fee-for-service does the reimbursement, but there's the option to contract with ACOs purely for a case management structure. So it ended up existing in both the pros and the cons, that if ACOs were to undertake that, ACOs have a very good case management structure in place already. This was a point of emphasis, not really a pro, but just one of the things that would have to be emphasized in any case management activity is that there needs to be rigorous outreach to members that don't have current contact with providers or plans, helping to educate them about resources, and helping to compensate for current provider services to members. That's somewhat related to my previous comment. Another pro that was mentioned was that fee-for-service has the fewest barriers for members and their access to providers. It was stated that rural members can get access to services in urban areas with fewer barriers and there's fewer geographic limitations. This speaks particularly to its current state, where it's statewide fee-for-service. It's one payer. That is one of the pros of it, that an individual from San Juan can receive service in Sully County, and it's the same payment structure. And again, I think I just emphasized that, but one system that meets all needs, integrated delivery, and it's easy to communicate the service to members and providers. As far as the cons, so already mentioned this, but ACOs have a case management structure in place, and it is NCQA accredited. Cons to this fee-for-service plus case management structure is it is kind of developing a new infrastructure where case managers do not have as much familiarity with these individuals. There would be a learning curve, and there's also some budget constraints. If it's run by the department or a contractor, we would have to be mindful of our ability to hire, train, competitively recruit, all of those things in a nimble way. So that would be a challenge. Eligibility changes would need to be a focus. This has been a topic of previous discussions, but individuals may not stay TAM forever. If a TAM member becomes pregnant, for example, they move to a legacy population. And if the service structure is radically different, that could create some discrepancies in the member's care as they move from delivery model to another delivery model. And then the question of scalability. This is kind of that question of competitively recruiting, hiring, firing case managers as needed. How would we meet the workload and scale it? So we will get into more of that detail in the geographic assessment. So it was also pointed out again that 56% of the population is in Sully County. And as a point of comparison, so San Juan today only has 12 TAM clients. So obviously that wouldn't be feasible for a single FTE. So question is how to staff appropriately when you may have one case manager that is focusing on several different geographic areas. This population has a very small rural distribution, and we need to consider the client's ability to travel and receive care in different counties with potentially different delivery models. So the recommendation from the subgroup is a staged approach. I'll go into more detail in a moment on that. But this was envisioned as sort of a fallback to other options, that this was not the preferred delivery model, at least among our subgroup participants. We would propose rolling it out to members where a county did not elect to use one of the other delivery models. And when it is the delivery option, there would need to be the emphasis of teaching members basically those healthcare literacy standards, how to access service, what their access points are, inform consumers how to navigate those resources, because they may be transitioning between models, and it's important to consider the patient experience to reduce fragmentation and increase integration. So that was the subgroup's recommendation related to geographic assessment. As far as population assessment, some of this is related, but it is, the bottom line is there was no proposed segmentation further than geographic. Nothing related to a TAM subgroup, age, condition that would lead the subgroup to recommend any further segmentation in delivery model. It was brought up this point that keep in mind members and their ability to access telehealth. And as I look at this, this may belong more neatly in geographic assessment, but the point is made that not all members can afford a data plan for telehealth. To the extent we want to discuss that further, First Step House did use some ARPA funds to allow members to get technology to allow them to access resources. So that was an interesting point that was brought up, and if we want, we can delve into that more later. As far as the proposed timeline for implementation, like I said, this would be sort of a fallback plan. Our group was mindful of the July 2023 date that is part of HB 413, that whatever the work group recommends, it would be for that date or a later date when the systems are prepared. So this proposal would be to at least begin fee-for-service plus extensive case management in July 2023, but continuously allow for counties to adopt one of the other models over time as they change from fee-for-service to a different model. And one of the closing thoughts, Alan contributed this, I thought it was a good thought, but it was about value-based purchasing and whether it could have a fit in fee-for-service. There was the discussion that payment arrangements with limited risk could be used to pay for outcomes rather than service. Again, to capture some of those things that don't correspond to a procedure code. So this may be a model in a county that doesn't have large numbers of TAM enrollees, like San Juan County as an example, but allow providers to receive payment for services that cannot be translated to those procedure codes. So certainly a lot to take in, but I'm happy to take any questions. Go ahead, Tim.
Hey, Brian, that was a great summary. The one other thing I would add is we have certain creative codes that really assist this population on the managed care side. They're not currently available on the fee-for-service. One of it, which is an H code, H2016, supported living. And it allows us to leverage Medicaid dollars to have 24/7 staff on site at some supported living programs. The way the rate is created, what the managed care organizations pay the provider, is based upon really that specific facility and program. And so I don't know how you would get to creating that kind of a rate or a benefit for the fee-for-service, but for our population, it is a really important benefit that we would want to have. So that's the only comment I would have for you on that.
Thank you, Tim. And that's the B3 service, right? So that would exist as a con for the fee-for-service model.
That's correct.
Well, I would say, Brian, it doesn't exist now for fee-for-service, but one of the considerations could be to make those a state plan service, that certainly is going to create additional cost. Because the whole concept behind B3 services and managed care is that if the entities are managing care, then they have these reserves or funds that essentially are available, and they can provide these services by using those savings. But there is also an option of maybe pursuing these as state plan services, but that will come with additional cost.
Hey, Emma, it's Tim. I really pursued this. Not to disagree with you, you're the Medicaid expert, but I pursued this recently with Medicaid leadership and was told that the only opportunity that could be would be if it came into managed care. So I'm happy to hear that it could be state plan, but I just wanted you to know I've been pursuing that recently with the Medicaid office, and that's what I was told.
I mean, right now it does only exist with managed care, but I think we could explore whether or not we could make it just a state plan service.
All right, thank you.
Thanks for the comment, Tim. Any other questions or comments?
Hey, Brian Pat Fleming. Hey, could you go up to you talked about case management services. I think it's okay. Yeah. Again, I'm looking at this through the lens of the TAM population. Most of those individuals are going to be going to, one of the local authority programs. I would think a lot of them would be. And of course, there already are case management services available there through them. Again, it's the same question I had with Eric. Is you have down there? Is that local health department? Is that what that means?
Yeah, it was actually asked by a work group participant as a potential. Could the case managers be employed by local health departments? And that was one of the, I mean, we would look to this work group to advise us on that. I mean, any thoughts on that?
Well, my thought is you're adding one more cook in the kitchen here, and I'm not sure. I think it would, to add even if you had a contract, let's say Department of Health and Human Services decided to have one large contractor providing case management services. Another cook in the kitchen, from my perspective, especially for the TAM population. So I just think we need to be kind of careful about that.
Understood. Yeah, good point. Any other comments? Thank you, Pat and Tim.
I just have one last comment, Brian. Why did you leave me, and why wouldn't you come back to work for me when I try to recruit you back?
That's beyond the scope of this work group, but I appreciate it, Tim.
Yeah, nice try, Tim.
I gotta try.
Well, good. Looks like most of the discussion was, well, it was a very good discussion. Thank you. Jen, any other items you'd like to add?
Yeah, I don't think so. I think what we want to do is what we had discussed earlier is that at the end of this meeting, we wanted to make sure that we were able to listen to the minutes and go through and add our comments, make sure these documents were updated to capture the additions that were brought forth. We also, and we will share these with you. Okay, so these two today. We would like to reconvene our subgroups one additional time to really firm up the recommendations as they stand, and really say, is this a feasible option, right? And really get a firm recommendation. I think the work that's been done right now was preliminary. While it's pretty comprehensive, there are other things we may want to consider adding and really thinking about. But we'd love to get the subgroups recommendations on, is this the feasible option we want to put forth? And then bring that back to our working group for just sort of a final closing discussion as we then move into our final phases of looking at what it could look like. The third item is that at our, we had at this point today, Brent was unable to be in this meeting because of another meeting he's attending right now. So we want to make sure in 2 weeks that we will hold this meeting again for our larger working group so that he has the opportunity to bring back that third subgroup and review those recommendations. And I know there were items for follow-up that we really wanted to have. So there may be another subgroup meeting for that RFI group in between our next 2 weeks to be able to kind of have a little more discussion around that subgroup as well. So next meeting, what we'll plan to do then is, first of all, make sure that you have the notes from these 2 documents we covered today, our ACO model, our fee-for-service plus case management model. It will include the original notes as well as some topics that were brought up and discussed today. Those will be shared with you in preparation for our next meeting in 2 weeks. So you'll have a chance to see them. We can certainly go through those and have any more discussion. If our sub-working group groups are going to meet one more time, Eric and Brian, for the 2 of you, you want to touch base with your subgroups and reconvene and kind of finalize that proposal, as well as where we want to go with it now that we've had a chance to have a discussion, and maybe bring that back to a future meeting, whether that's in 2 weeks or a month from now. So that will be our future plan with this sub work group. I'll take any thoughts, feedback on that path. Any other thoughts or opinions about how we could run that differently, or if we're all in agreement with that, then we'll do that.
I think that's a good plan, Jen.
Okay. Okay. With that, we thank you for the input here. The one piece we had put out there that as our subgroups would meet again is there's a very last item. I believe that maybe it wasn't captured or covered as thoroughly today, but we did touch on it in our ACO meeting. What are those contractual requirements, or what are those must-haves that we have to detail? Because I think it's really important for us to appreciate. I mean, Eliana, you brought up a really good point, and Dr. Whittle, you as well, around some of those braided items and how we would contractually capture those in whatever model we put forth. So as we look at those, we spent our weeks going through sort of utilization, those extra services that are being offered today, some of them which may not be directly reimbursed by Medicaid, but are being provided and essential. I want to make sure that all that work produces the result we want, is making sure that it's part of where we're moving forward in our proposals for these models. And then the second piece is, how do we measure the outcomes of that? Okay. So I think that's an important next step for us to really think about as well, that we really didn't dive into as much today. We touched on them, but I think we could go deeper. And so that's an area I'd like us to explore as well. So hopefully you're all on board with that too, and get your thoughts going. So when we meet again, we can dive into those discussions. Okay. Great. So with that, we can move into item 5, our Q&A time. If there is any, do we have any thoughts or extra questions and answers you'd like to discuss this afternoon? Okay. If not, we can close the meeting. We are scheduled for September 2nd. That is Labor Day weekend. We recognize that. So let's just, I know some of you, like, you know, recognizing it's a holiday weekend, the importance of this work, I think we're doing a really good job getting down into the details and doing the work we're called to do. But also I want to be sensitive to where we are on September 2nd. If there is a barrier to some of you being present on September 2nd, could you please let Sharon, who organizes our meetings, let us know so that we can just meet in a month and go through our RFI work and come back to have these discussions. If that's a barrier for you to be present that weekend, as it's a holiday weekend, let us know. As a member, we want you here. We want you to be part of that discussion. So we'll be sensitive about attendance on that day. And we can go out another couple weeks if you're all okay with that. If not, we're planning on holding the meeting at this time, okay, at our regularly scheduled time. But if not, we're also okay to push it out another 2 weeks if that time doesn't work for you, because many of you will be gone. So, Tim.
Yeah, just really quickly, Jen, I think the braided funding question is going to be really important and very political. And so will it be the large group that tries to tackle that? I mean, as we look at what Arizona did, as they tried to get the service dollars available to the managed care organizations, they really had to restructure everything they did. And the dollars that currently are coming to the local authorities for safety net services, those service dollars that support some of the Medicaid gaps and other things, boy, that would be a humongous change to the system as you discuss that. So I'm not making any recommendations. I'm just saying that that's going to be a meeting that is going to be interesting and should be represented by all as we have that discussion.
Yeah, absolutely, Tim. And I see many others nodding their heads in agreement, and that will be part of our larger group discussion.
Thank you.
You're welcome. Thanks for bringing that up. Okay. Appreciate all of your contributions and your participation in this work. We really couldn't do it without you all. So thank you for giving your time to this important project. And we look forward to seeing you soon. Okay. Thank you.
Thanks, everybody.